Yes, ma'am.
Okay. So in today's class, we will be discussing from corticosteroids. Okay, corticosteroid is also a very effective drug for the treatment of chronic asthma. But it is not used in case of termination of acute attack of bronchial asthma because it is not a bronchodilator. Okay, it does not dilate the bronchial smooth muscles. That's why it is not indicated in case of acute attack of bronchial asthma. Okay, this is very important point because it is not a bronchodilator, so we cannot use in case of acute attack. So in any acute attack of asthma, you have to use first bronchodilators, okay, fast acting bronchodilators, okay, sympathomimetic drugs like beta 2 agonist, okay. But it is a very effective drugs in other points of view, like it is a strong anti-inflammatory drugs. That's why it is used for the management of chronic asthma, okay. If the patient require long-term treatment of asthma, then this is one of the effective drugs for the particular patient, okay. That's why it is also known as controllers because it controls the disease progression, okay. It provides the long-term stabilization of the symptoms due to their anti-inflammatory effect. I hope all of you know that corticosteroid is a strong anti-inflammatory as well as immunosuppressant drugs. No, it has a various use. It can be used for the various purposes. Okay, so likewise, it can be used very effectively in case of bronchial asthma for the management of chronic asthma. Let's see what are the mechanism. How does it help in the bronchial asthma? It enhances the beta 2 response by upregulating the beta 2 receptor. Okay, if the patient is that is resistance to beta receptors or beta 2 agonist, if you combine this beta 2 agonist with the corticosteroids, then the responsiveness of the beta 2 agonist will be increased. Okay, because this corticosteroid will upregulate the beta 2 receptor. Okay, this is a very important mechanism of corticosteroids. Likewise, it inhibits the release of prostaglandin and leukotrienes. Okay, these are the strong inflammatory mediators in bronchial asthma that cause inflammation of the bronchial smooth muscles and cause constriction. Okay, so it inhibits the release of prostaglandin. So this corticosteroid would inhibit this. I think all of you know this, how this arachidonic acid is going to form the leukotrienes and the prostaglandin. Okay, if you remember the NSAIDs class, this membrane phospholipids is converted into arachidonic acid. Okay, this is the first step of formation of the prostaglandin. Okay, that is acted by phospholipase A2 enzymes. Okay, so this corticosteroids will inhibit this phospholipase enzymes, okay, by formation of lipocortin. Okay, it is one of the protein that is stimulated by the steroids. Okay, that lipocortin will inhibit this phospholipase enzymes. Sorry. So this, if this enzymes is inhibited, then the other further process is inhibited. Okay, there is no formation of the arachidonic acid and there is no formation of leukotrienes and prostaglandins. Okay, thereby inhibiting the synthesis of inflammatory mediators. Okay, this is one of the important mechanism of the glucocorticoids. Okay, is an anti-inflammatory effect. Clear? And also it produces eosinopenia. That means it decreases the number of eosinophil. Okay, that's by inhibiting the release of the different mediators from the eosinophil. Okay, from the eosinophil there is a release of the leukotrienes as well as the proteins, activating factors, PAF. Okay, so all these mediators will be inhibited. Okay, or there is a decreased synthesis of this mediators if there is a decreased count of eosinophil. Okay, another way is it inhibits the formation and release of cytokines and chemical mediators from the mast cells and the eosinophil. Okay, from the mast cell also there is a release of leukotrienes, histamines and other various inflammatory mediators. Okay, tumor necrosis factor, protease activating factors. Okay, these are the different mediators that are released from the mast cells and the eosinophil. So this corticosteroid inhibit this mast cells and the eosinophil. So that is how it becomes one of the strong anti-inflammatory drugs. That's why we can term as a controller. Okay, this drugs also called controller. Which drugs are also known as relievers? Do you remember?
Bronchodilators.
Yeah, bronchodilators, they are the relievers because they provide the immediate relief to the patient, okay, by causing bronchodilation. But these drugs does not cause bronchodilation. These drugs does not produce the immediate relief to the patient. But in long-term use, it has a very much beneficial effect, okay, that control the disease progression by inhibiting the different release of the different inflammatory mediators like leukotrienes, okay, and histamines and other protease activating factors, and different inflammatory mediators are controlled by corticosteroids, okay. That's why it is also known as controllers. Okay, this is nowadays, this is one of the most commonly used drugs for the management of chronic asthma, okay, in combination with other drugs. You can combine with the long acting beta 2 agonist, sometimes you can combine with the theophylline, okay, sometimes you can combine with the anticholinergic drugs, okay. So I hope all of you know that corticosteroids has many adverse drug reaction as well, no, in long term use. That's why these drugs are used by the inhalation route, okay, in the form of MDI, meter dose inhaler. Okay, as far as possible, always we have to use corticosteroids in MDI, okay, in aerosol form, unless and until required. There is indication of the oral or the other intravenous. Okay, in some condition we have to use oral preparation also. In some condition we have to give intravenous also, in like in immediate that is emergency condition like status asthmaticus, or the person the asthma is very severe, okay. Otherwise in every cases of bronchial asthma we have to manage by giving MDI, meter dose inhaler, or aerosol form of the corticosteroids, okay, to release the systemic side effect. Because in systemic use corticosteroids has many side effects, okay. It affects every organs of our body. Because of its various mechanism of action, it afford more complete and sustained systemic symptomatic relief than bronchodilators or the chromoglycate. Okay, that's why we can use for the chronic use, for the long-term use. That improves the airflow, reduce asthma exacerbations, and may influence airway remodeling also, okay, and retarding the disease progression. These are the advantages of glucocorticoids in bronchial asthma. The mechanism, all of you know this. There are various preparation of glucocorticoids, okay. It is available as oral, IV, and MDI preparation. But this MDI is preferred because of the fewer side effect, okay. So wherever and whenever possible, always prefer the MDI route, okay, that is inhalation route. There are various preparation, okay. Oral, in oral we can use prednisolone, and methylprednisolone. In parenteral, we have hydrocortisone and methylprednisolone. In aerosol or MDI, beclomethasone, triamcinolone, fluticasone, budesonide, and prednisolide. Okay, these are the different drugs which can be used in MDI device. Okay, meter dose inhaler, either single or we can combine, or it is available in the combination with other drugs also. Okay. There are certain uses or certain indication of the systemic steroid also, okay, like in case of severe chronic asthma not controlled by the bronchodilators or other inhaled steroids. In that condition we have to start oral preparation, okay, like prednisolone 20 to 60 milligram daily. And I hope all of you know that when we are using the corticosteroids for more than 1 to 2 weeks, always you have to taper down the dose of the particular drugs. Okay. We know the reason why we have to taper down the dose of glucocorticoids after using a long time or more than 1 to 2 weeks. Anybody?
That adrenal cortex will not make forward after.
Okay, there is acute adrenal cortical insufficiency. Okay, because of that reason, to prevent that adrenocortical insufficiency, acute adrenocortical insufficiency. Okay, so to prevent that, we have to taper down the dose, because if you are using the corticosteroid from outside and our cortical gland, they stop producing the glucocorticoids, no? That's why we have to slightly decrease down the dose. Day by day, we have to decrease down the dose and stop. And in case of status asthmaticus, okay, it is a very severe form of the acute severe asthma, okay, in which the patient may suffer from the different symptoms, okay, severe breathlessness and very chest pain and others, okay. So this is a very immediate or emergency condition. You have to treat the patient as soon as possible. If the treatment is getting late, the patient may die, okay. So in that condition, you have to give the intravenous route that provides a faster effect, okay. So for that, we have to give the rapidly acting glucocorticoids by intravenous route, like different glucocorticoid, like the corticosteroids, hydrocortisone we can give, or methylprednisolone, okay, in injection, which acts 6 to 24 hours. And after 24 hours, after the patient becomes stable, then we can shift to oral therapy, okay, for 5 to 7 days to prevent the relapse, and then taper down slowly. And this systemic therapy also can be used for the chronic obstructive pulmonary disease patient or COPD patient, okay. So these are the some indication of the systemic steroid therapy. Otherwise, these steroids, they are used by the MDI or inhalation. These inhaled steroids, they are indicated in every cases of persistent asthma, okay, along with the beta-2 agonist. You can start with the 100 to 300 microgram twice a day, and after that you have to titrate down the dose. Either the patient responses, what is the response, okay. If that patient is getting well with that particular dose, then you can continue with that dose, okay. If the condition become worsen, then you have to increase the dose of the drugs, okay. So depending upon the response of the patient, you have to titrate the dose. Either you have to decrease or you have to increase the dose, okay. And you can give maximum 400 microgram 4 times a day. And beyond that, there is no any beneficial effect of corticosteroid. If this dose does not control the patient symptoms, then you have to change to other drugs, okay. You can give other drugs. You can give anticholinergic, or you can give other long-acting beta-2 agonist or other drugs, okay. Peak effect is seen after 4 to 7 days of instituting inhaled steroids, okay, because these corticosteroids, they act by nuclear receptor, okay. When the drugs act by the nuclear receptors, they will take many hours to do their action, okay, because they are acting through the nuclear receptor. So they take time for the transcription, translation, okay. That's why we have to wait at least 1 week, okay, to get the effect of corticosteroids. Immediately it does not produce any effect, okay. After 4 to 7 days of giving corticosteroids, then the drug start working, okay, because it act through the act by the nuclear receptor, okay, cytoplasmic receptor. Short courses of oral steroids may be added during periods of exacerbation. So when there is a condition of relapse, or when the asthma is occurring frequently, then short course of steroid therapy is added in between the inhaled therapy, okay, to prevent the relapse. There are various adverse drug reaction of glucocorticoids, but when we are using by the inhalation route, there is no systemic absorption. That's why decreasing the side effect of the drugs, okay. Certain side effect like hoarseness of voice, dysphonia, sore throat, oropharyngeal candidiasis, these are the very common side effect by inhalation route. So after every use, the patient should rinse their mouth, okay, to prevent this oropharyngeal candidiasis. Or we can minimize by giving spacer, okay, by using spacer, gargling after every use. Or if the condition is severe fungal infection, then we can give antifungal drugs, okay, by topical route. And if the patient is using by the systemic route, then there are various side effects, okay, like mood changes, osteoporosis, growth retardation in the children, petechiae, hyperglycemia, hypertension. Okay, there are various side effects of the glucocorticoids when it is used by the systemic route. either intravenously or orally if it is used for the long time. So the systemic route is not preferred in case of bronchial asthma, okay, unless and until there is indication. The drug is safe during pregnancy, okay. If it is inhaled, then it becomes safe during pregnancy also. And various dose of the different drugs, okay. This dose and duration frequency you can read from the books, okay. For MDI it is different dose, for Rotacap inhalers it has a different dose, okay. Now another group of the drug, that is mast cell stabilizer, okay. These drugs also, they are not a bronchodilators, okay. That these drugs, they act by stabilizing the mast cell, okay. The mast cells which is responsible for the release of various inflammatory mediators like histamine, leukotrienes. So these drugs will stabilize the mast cells and thereby preventing the degranulation of the mast cell and inhibiting the release of different mediators, okay. Histamine, leukotrienes, and the platelet activating factors that prevents bronchoconstriction, okay. We have three drugs: sodium chromoglycate, nidochromyl sodium, and ketotifen. So because these histamines, these are the allergic mediators, okay. They produce the allergic type of allergic asthma, and also they produce other allergic rhinitis, allergic conjunctivitis, okay. These drugs are used for the other purpose as well, okay. Besides bronchial asthma, we can use in the allergic rhinitis, allergic conjunctivitis, and other allergic reaction. Since this sodium chromoglycate is not effective, is not absorbed orally, okay, so we have to give by inhalation route this sodium chromoglycate. But this ketotifen, they are well absorbed from the oral route. This ketotifen we can give by the oral route, okay. Other uses and other mechanism are almost similar, okay. Nidochromyl sodium and ketotifen, they are used for bronchial asthma for prophylaxis, okay. Some patients, they are more allergic within certain seasons like spring seasons, okay, when there is a various pollen grains of because of pollen grains and particles, they are allergic in certain weather, okay. Before coming to the that particular weather, the patient has to be given the prophylactic drug therapy, okay. For the prophylaxis, it is a very effective drugs, okay, that prevents the release of the allergic mediators like histamine, okay. So basically these drugs are used for the prophylactic purpose, okay, for bronchial asthma. And we have to start before the season start, okay. At least 1 month before the season we have to start this drug, and after completion of the season also we have to continue for at least 1 month, okay. This is how we use this drug as a prophylactic. This also can be used for the allergic rhinitis, because this allergic rhinitis also is due to the histamine, okay. Allergic conjunctivitis also we can use this drug. There's some adverse drug reaction of this drug, like with fine powder inhalation, there is a bronchospasm, throat irritation, cough, headache, dizziness, arthralgia, rashes. These are the common side effect of sodium chromoglycate, okay. These drugs also used by the inhalation route. And ketotifen, they produce sedation, dry mouth, dizziness, nausea, and weight gain, okay. This sedation is due to the H1 blocking effect, okay. This ketotifen also blocks the H1 receptor, that's why it produces the sedation. Clear? In which condition we can use this mast cell stabilizer? What are the uses of mast cell stabilizer? These are not used for terminating the attack, okay, because they are not a bronchodilators, and also they are not used for the chronic management of bronchial asthma, okay, because they are not the anti-inflammatory drug. They are just preventing the degranulation of the mast cell. So these drugs are used for the prophylactic purpose basically. Next we have the anti-IgE antibody. Okay, in this we have one drug omalizumab. Okay, this anti-IgE antibody, this will inhibits the binding of this antibody, IgE antibody, to the mast cell. Okay, so thereby preventing the binding of this IgE antibody into the mast cell, because this omalizumab will go and bind to the mast cell receptor, okay, where this IgE is binding. That's thereby preventing the binding of IgE with its respective receptor in the mast cell. And it attaches to the free circulating IgE and prevents its binding to the mast cell. So that's why it is not a suitable for the acute attack. So this is only used in case of some resistance cases, okay, when this asthma is not cured by the other drugs. So we can use an add-on therapy with other drugs, as we can combine with the corticosteroids, also we can combine with the beta-2 agonist, or in some condition when there is a increased level of the IgE. Okay, in that condition we can use as add-on therapy. It is given by the subcutaneous route, and because it is a monoclonal antibodies, okay, it is a very expensive drugs. Okay, all the patient cannot afford this drug. This is also another disadvantage of this drug. Okay, so we have finished different groups of the drugs that are used in bronchial asthma. Okay, now is a summary. I have prepared one table, okay, with different classification of different asthma along with their treatment. Okay, what is the treatment and what is the prophylaxis for that bronchial asthma. Okay, so different classification like mild episodic asthma, seasonal asthma, we have mild persistent asthma, okay, moderate, severe, and status asthmaticus. So how we are going to treat a patient having a different type of asthma? First we should know, okay, the particular patient having which type of asthma, either it is a mild type or it is a moderate type, okay, either it is a seasonal asthma or it is a very severe type. Okay, accordingly we have to treat. The mild episodic asthma means the attack is less than 1 per day. Okay, the patient may suffer from either 1 attack or less than, or sometimes it's no attack in a day. Okay, that is a mild episodic type. And pulmonary function test is normal. Okay, in this condition we can give the patient short acting beta-2 agonist for the termination of the attack only. Okay, there is no requirement of the prophylaxis. In seasonal asthma we have to give the drugs like mast cell stabilizer, okay, sodium chromoglycate drugs, inhaled steroids or inhaled steroids 1 month before the season start, and continue 1 month after the season is over in case of seasonal asthma. Okay, there is no need of giving short acting beta-2 agonist like salbutamol. Okay, only we are giving as a prophylactic treatment. So for that sodium chromoglycate is the suitable drug. In mild persistent asthma, the 1 attack per day. Okay, the patient may suffer from 1 attack in a day, and pulmonary function test is near normal. Okay, in that condition, we give quick relief by the beta-2 agonist, and for the prophylaxis, we can give either the low dose inhaled steroids or inhaled chromoglycate. Okay, sodium chromoglycate for the prophylaxis. Moderate asthma is characterized by more than 1 attack per day. Okay, either 2 or 3 attack per day. Okay, so for that we can give beta-2 agonist, okay, short acting beta-2 like salbutamol inhaler during the attack. Okay, and for the prophylaxis, low to medium dose inhaled steroids along with the long acting beta-2 agonist, or instead of long acting beta-2 agonist we can give theophylline or the montelukast. Okay, that is how we are going to treat a patient having moderate asthma. And in case of severe asthma, we are giving inhaled short-acting beta-2 agonist for the quick relief. Okay, and for the prophylaxis, we are giving the high-dose inhaled steroid along with the long-acting beta-2 agonist. Okay, sometimes beta-2 agonist again combined with the other drugs like theophylline, montelukast, or we can give the anticholinergic drugs. Okay, ipratropium bromide or the tiotropium bromide. Because in severe asthma, there is a continuous symptoms. Okay, so for that we have to give high dose steroid along with the long acting beta-2 agonist. And in case of attack, acute attack, then we have to give short acting beta-2 agonist. Okay, for termination of attack. So this is how we have to treat a patient of bronchial asthma. Okay, and severe asthma, and there is another very complicated or complex form of the asthma. Okay, this is a very emergency condition, status asthmaticus. It is an acute severe condition. Okay, which is a very life-threatening condition. And if the treatment is delayed, the patient can lose their life. So you have to treat the patient as soon as possible. Okay, by the combination of the various drug. It is maybe due to the upper respiratory tract infection, which is not cured by the antibiotics, or maybe due to the previous asthmatic patient, okay, which are not adequately controlled because they are not taking the drugs in proper time, in the right amount, okay, in the right frequency. Okay, because of that, the patient may suffer from the acute attack, okay, continuous attack of bronchial asthma. So it is a very severe case, emergency condition. Okay, the patient may suffer from tachypnea, labored respiration with increased effort on exhalation, suprasternal retraction, or diminished breath sound. Okay, these are the various symptoms of sign and symptoms of status asthmaticus. Tachycardia, elevated blood pressure, and at last, if the condition is very severe and if the person is not getting treatment at time, then the patient may suffer from heart failure, and finally there is a death of the patient from suffocation because the patient cannot respire. Okay, because there is a severe constriction of the airways. So you have to give the aggressive treatment as soon as possible. So first of all, we have to hospitalize the patient in the emergency department, okay? And we have to check all the ABC of the patient, airway, breathing, circulation, and dehydration of the patient. And accordingly, we have to give, okay? If there is an electrolyte imbalance, we have to give electrolyte, okay, like normal saline or the dextrose. And if the artificial respiration is required, then we have to give artificial respiration. And if the person is dehydrated, then you have to give adequate hydration to the patient. Okay, this hydration is also helps to prevent the sputum being sticky. Okay, and for the termination of the attack, always you have to use short acting bronchodilators. Okay, salbutamol, nebulized salbutamol by inhalation, or in case of attack, severe attack, we have to give intravenously, okay, for the fast action. So salbutamol 250 microgram IV can be given over 10 minutes, okay, for the termination of the acute attack. And if the patient becomes stable, then we can give the anticholinergic drug, okay, ipratropium bromide combined with nebulized salbutamol. And also you have to give hydrocortisone hemisoxinate 100 milligram intravenously, stat followed by 100 to 200 milligram 4 to 8 hourly infusion. Okay, this hydrocortisone also very much required to prevent the inflammatory mediators. Okay, but it will take some times to act. Okay, because this bronchodilators, they start working, no? They provide the immediate relief to the patient, and also we are giving anticholinergic drugs as well. Okay, after then we have to start hydrocortisone, corticosteroids, and the high flow humidified oxygen inhalation is also required, intubation and the mechanical ventilation if needed. And if the person having the chest infection and we have to treat the patient with the adequate antibiotics like amoxicillin, okay, 500 milligram 3 times a day. We have to treat the chest infection. And if there is a dehydration, then we have to correct dehydration by giving normal saline or the dextrose, okay, adequate fluid. And if there is a acidosis, then we can give sodium bicarbonate. Okay, this is how we have to treat a patient of status asthmaticus, okay, immediately to save the life of the patient, because it is a very emergency condition. Okay, if the patient get delayed because of if he is not getting drugs in time, okay, in time, then he may lose their life. Okay, are you clear about how to manage status asthmaticus? How you are going to treat a patient of status asthmaticus?
Yes, ma'am.
Okay. If you have any doubt, you can ask. We have finished bronchial asthma. Can I start the next topic? Very short. Okay, it is a short topic. Just we should know the management. I think all of you know what is chronic obstructive pulmonary disease. Okay, say COPD. What is the pathophysiology of COPD? What are the etiological factors? I think you have already learned in the pathology and other subject as well. No? Yes or no?
Yes, ma'am.
Okay. Can you define what is COPD? Chronic obstructive pulmonary disease. How it differ from bronchial asthma? Anybody? Nobody is responding. Why? Do you want to continue, or I have to stop here only?
Ma'am, COPD is not allergic. It can't be allergic.
Okay, it is not allergic. Now, what are the causative factors? What is the pathophysiology behind COPD?
Smoking, tobacco,
Smoking is the main cause.
air pollution.
Yes, yeah, smoking, other very environmental pollution, occupational exposure. Okay, those person who are working in the various industries like the coal tar industries, or they are very much exposed to the smoking dust particles. Okay, that type of patient, they are very much prone to the COPD. That is a chronic obstructive pulmonary disease. That means there is a progressive obstruction of the airflow. Okay, the patient may feel suffer from breathlessness, okay, dyspnea. Along with that, there is a copious amount of the sputum, okay, productive cough. But in asthma, there is no cough, no? Cough is not there. And this is mostly associated with the chronic smoker also, okay? Those person who are chronic smoker, they are very much susceptible to COPD, okay? As well as if there is a respiratory infection for the long time, and the patient is not treated with the antibiotics, proper antibiotics also, okay, that may ultimately lead to COPD. And the other factors like the bronchial asthma is mainly due to the histamine, neutrophils. The inflammatory mediators are also different, okay. These are mostly due to the neutrophils, okay, increased concentration or increased release or activation of the neutrophils. Okay, this COPD is due to the activation of the neutrophils, and they are associated with the two hallmarks, okay, that is with chronic bronchitis and emphysema. Okay, they are associated with the two symptoms. And there is a decrease or decline in the forced expiratory volume in 1 second. Do you know what is FEV1? forced expiratory volume in 1 second? That, do you know?
Amount of air expired in this parameter in 1 second.
Yeah, the amount of the air that is expired by the particular patient in one expiration, forceful expiration. Okay, that is a forced expiratory volume. So this forced expiratory volume become very much declined. Okay, abnormal decline, that is more than less than 50%. Okay, in the COPD. But that condition is not seen in the bronchial asthma. So you should be able to differentiate either it is a bronchial asthma or it is a COPD. And COPD is basically associated, they are associated with the chronic bronchitis and emphysema. So in chronic bronchitis, there is inflammation of the bronchial smooth muscles and there is a mucosal edema. Okay, that may lead to the obstruction of the airways. And because of the airways becomes very narrow. And at a later stage, okay, in the severe form, that may lead to the cor pulmonale, that means the right sided heart failure, okay, because of the pulmonary hypertension. Okay, the pressure is created in the lungs that ultimately leads to failure of the right side of the heart. Okay, that is known as severe cor pulmonale. So it is a consequence of the chronic bronchitis. Okay, and another is the emphysema. Emphysema is the enlargement of the small airways. Okay, and there may lead to lose their tonicity, also elasticity. Okay, ultimately there is a decrease or narrowing of the airways. Okay, so the patient may suffer from the dyspnea, breathlessness. Okay, so these are the characteristic features of the COPD. Clear? Are you getting it? So there is an increased neutrophil and the macrophage activation, whereas in bronchial asthma, there is an increase in the, there is a degranulation of the mast cells and release of the histamine and other inflammatory mediators, okay, leukotrienes and others, platelet activating factors and the tumor necrosis factor. Whereas in this COPD, there is increased neutrophil activation and macrophage that leads to the various chemotactic factors like leukotriene B4 and interleukin 8 and protease. Okay, that leads to inflammation of the airways and destroy the tissue of the alveolar wall. Okay, and thereby narrowing the airways. That's why the patient may suffer from breathlessness, dyspnea. Okay, and also there is increase in reflex cholinergic tone in the bronchial smooth muscles. Okay, that lead to constriction of the bronchial smooth muscles. These things I have already explained in the anticholinergic drugs. Okay, while I taught you in the anticholinergic, I explained this, why these anticholinergic drugs are more effective in COPDs. Okay, because there is increase in reflex cholinergic tone that may lead to the constriction of the bronchial smooth muscles. The symptoms, they are shortness of breath, chest tightness, wheezing, lack of energy, weight loss. Okay, this is also one of the features. Okay, symptoms of this COPD, weight loss. Okay, frequent respiration infection, respiratory infection, which is not controlled by the antibiotics. Okay, chronic cough with the clear or the colored phlegm. Okay, that is a colored sputum. Blueness of the lips or the fingernails. This is due to the cyanosis. Okay. So you should know how to manage COPD patient. So what is the aim of the treatment of COPD? First, we have to give the symptomatic relief to the patient. Okay, by increasing the airflow. Okay, by increasing the airway passage. Okay, so first we have to lessen airflow obstruction. Okay, by giving the bronchodilators like beta-2 agonist. And the next important aim of the treatment is to reduce the respiratory symptoms and improve quality of the life of the patient, and to prevent and treat secondary complications like hypoxemia, infection, and the cor pulmonale. If there is a respiratory chest infection, then we have to give proper medication, antibiotics. Okay. First, if the patient is a chronic smoker, okay, the first thing is the person should stop smoking. Okay, this is one of the etiological factor for COPD. Okay, stopping smoking is very, very important. Okay, the patient should stop smoking, and the person should give influenza vaccine every year. Okay, and if there is a chest infection, if the COPD is due to the infection, chronic infection, then we have to give proper antibiotics. And for the termination of the attack, okay, for the termination of, to give the immediate symptomatic relief, we have to give bronchodilators. Okay, short acting beta 2 agonist like salbutamol we have to give immediately, okay, to reduce bronchospasm and wheezing, which provides the rapid relief. If you are giving by the inhalation, to start anti-muscarinic drugs, okay, like ipratropium bromide and tiotropium bromide, which are more effective than beta 2 agonist in case of COPD. Okay, why they are more important, more effective? That things I have already explained in the last class. Okay, because in COPDs the cholinergic tone are the main mediators for the constriction of the smooth muscles. Okay, that's why these anti-muscarinic drugs are very much effective in case of COPD patient. Beta 2 are giving to provide the symptomatic relief to the patient. Okay, for the long term use, we should give this anti-muscarinic drugs. And also we can combine this anti-muscarinic along with the long acting beta 2 agonist also. Okay, xanthine derivatives like theophylline, aminophylline also can be given orally. Okay, along with the inhaled bronchodilators to improve the respiratory muscle function. Okay, this theophylline, this is also a bronchodilator that act by the various mechanism, by inhibiting the adenosine receptors and by increasing the cyclic AMP concentration. Okay, and also by increasing the cyclic AMP concentration in the mast cells, thereby decreasing the inflammatory mediators. Okay, so this is also very effective drugs, but because of its various toxicity, okay, narrow therapeutic window, these drugs are not so much used frequently. But we can sometimes give in combination with the bronchodilators in case of COPD. So that will improve the condition in cor pulmonale also, because it also have a positive inotropic effect. Okay. And in some patient, that corticosteroids will provide the good response. Okay, so for that we can give prednisolone 30 to 40 milligram per day for 15 days. And after that, we can continue with the inhalation steroids, because this that oral we cannot continue for the long term. Okay, so we can switch over to inhalation steroids. Okay, after 15 days, switch over to the inhalation corticosteroids. In case of severe COPD and persistent hypoxemia, use of the domiciliary oxygen. Okay, high flow oxygen should be given 15 hours a day. Okay, to for the treatment of hypoxemia, because there is a decrease in the oxygen saturation in severe COPD patient. Okay, so we have to give the continuous oxygen therapy. Okay, domiciliary oxygen, high flow oxygen for 15 hours a day, which reduce the associated mortality and risks of complication, because most of the patient they die of COPD due to the hypoxemia. Okay, decrease in the oxygen saturation. So for that we have to give continuous oxygen flow for 15 hours a day. Okay, that is one of the very important things we should do in severe COPD patient to reduce the mortality and other risk complication like cor pulmonale. Okay, and other neuropsychological impairment also can be seen in case of severe COPD. So to prevent that, we have to give continuous oxygen flow. Okay, 15 hours a day. So this is how we have to manage a patient of COPD. So at first you should know what are the drugs used for the termination of the attack, okay, which provides the immediate relief to the patient. Okay, the patient of chronic asthma or the severe asthma or the COPD, they come to you with a complaint of breathlessness and the dyspnea. Okay, this is one of the presenting features of either chronic obstructive pulmonary disease or bronchial asthma. So as soon as the patient come, you have to give the drugs that relieve the symptoms of the patient. Okay, for that you have to give, always start with the short acting bronchodilators, beta 2 agonist. Okay, salbutamol you have to give immediately. Okay, as soon as the patient come to you, you have to start salbutamol. If the condition is very severe, you can give by the intravenous route. Otherwise, if the patient is stable and you can take by the inhalation route or through MDI, then start from the MDI. Okay. So this finished our COPD also. Okay, I have finished bronchial asthma and COPD. So if you any doubt, if you have, I think we will have next class also, no? Because of the internet problems, I couldn't finish in time. I'm very sorry for that. So I will take your attendance. If you have any doubt, we will discuss in next class. Okay, you go through the slide. I will upload in your team channel. Thank you, all of you. You may leave.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am.